terms of axial pain in the lumbar spine and in the entire spine, we have discogenic pain, vertebrogenic pain, and now we have a traumatic pain, the traumatic etiology that is osteoporotic compression fractures. So we're going to spend the next little bit of time talking about vertebral augmentation for osteoporotic compression fractures, and we'll discuss the mechanisms of safe transpedicular access, which will also play into the utilization for basivertebral nerve ablation. So the history, back in the 70s and 80s, vertebral augmentation was primarily a surgical procedure. And we used polymethylmethacrylate, PMMA, was used to fill a void after a tumor resection, or in some circumstances to provide additional purchase for pedicle screws in spinal instrumentation when the patient was significantly osteoporotic or there was tumor present. It was developed as a percutaneous procedure in France by Hervé Darrimond and colleagues in 1984, and here is the index patient for all vertebral augmentation. This was a 54-year-old female with intractable C2 radicular pain, and she had an aggressive hemangioma, a benign but aggressive tumor with epidural extension. And she underwent a surgical resection, C2 laminectomy and epidural resection, and that involved a curettage of much of the C2 body. And to fill that void, a needle was introduced from an anterior vector, and the C2 body was filled with polymethylmethacrylate to prevent its collapse. So that is the index vertebroplasty case. Galabert and Darrimond, the colleagues from Amiens, France, introduced the pacification of bone cement with radiodense materials such as barium, and later developed the transpedicular approach from a posterior vector, as we see here, to provide safe access to a vertebral body. Additional colleagues in France then applied vertebroplasty to osteoporotic and malignant compression fractures, primarily using CT guidance. Then Jensen and Dion at the University of Virginia in the US evolved the Darrimond technique using fluoroscopic guidance and introduced it into clinical practice to treat osteoporotic compression fractures in the mid-90s. And I learned this from Jensen and Dion back in the day in the late 90s. Synchronous with this, balloon-assisted vertebroplasty, or kyphoplasty, was developed by Riley and colleagues as a means of reducing fracture deformity. So here we're placing a very tough balloon through a transpedicular approach into the central vertebral body, distending it, and hopefully elevating that end plate. I say hopefully because it is not universal, and the amount of actual height restoration is extraordinarily variable. The other thing this does is it creates a void, and that allows you to instill a higher viscosity of cement. And that higher viscosity cement is less likely to leak into paravertebral veins or the epidural space and do bad things. So it does have at least a potential safety advantage. And it has now become the dominant form of vertebral augmentation in the US, and it accounts for about 2/3 of augmentation. There were significant challenges early on to the Kyphon company as they had some very inappropriate marketing in their product. So what's the prevalence? Well, this is a pretty common problem. In the US, we have over 750,000 new vertebral fractures annually, and about 1/3 of those experience a significant acute or chronic pain. And 20 to 30% are multiple at presentation, so we really need to image the entire spine. And how do we define a fracture? About 20% vertical height loss or 4 millimeters of absolute height loss. If we look worldwide, the worldwide prevalence is, in populations more than 70 is about 20%, so this is extremely common. Also, does it have a clinical impact? Yes, it does. There's a 5-fold increase in likelihood of adjacent or remote fractures in the first year after a fracture, and a significant increase in mortality in that first year after a fracture. What happens is these patients have diminished mobility, resulting in decreased pulmonary function, decreased risk of increased risk of pneumonia, DVT, pulmonary embolism, and also the debilitating effect of social isolation. So in terms of clinical presentation, they present with acute or chronic pain that may or may not have radicular features. The history of trauma may be completely absent. In fact, a third of these fractures occur while the patient's in bed. They have increased pain bearing load, as you would expect, and ambulating. And pain generally localizes to the fracture site. The one exception to that is the Main syndrome, where fractures at the thoracolumbar junction, T12L1, will refer pain to the iliac crest through the cluneal nerve distribution. These patients generally have pain with palpation or percussion at the fracture level, and that's extremely important in terms of localizing which fracture may be painful. And the neurologic exam is usually, but not always, normal. So indications for vertebral augmentation when we have painful osteoporotic compression fractures, which are refractory to non-invasive medical therapy. I mean, many of these patients will get better over time, but those who don't may require intervention. We may see vertebral bodies weakened by neoplasm that we can treat, and also patients who do not actually have any loss of height, but have signal abnormality on MRI or lytic lesions seen on CT that are symptomatic. We're going to assess them with a history and neurologic exam. Establishing a baseline neurologic exam is critical. A focused physical exam under fluoroscopic guidance. If I'm going to treat a fracture, I want to know that that fracture is painful. We percuss them under fluoroscopic guidance, or even try and grab that spinous process and vibrate it, wiggle it, and make sure that does indeed stimulate their pain. And then review imaging of the entire spine, looking for marrow edema, and looking at the integrity of the posterior vertebral body cortex and the pedicular morphology for our transpedicular access. Just some illustrations of the findings we see with imaging. We're going to see geometric deformity here, a wedge-shaped deformity, very obvious. Low T1 signal, elevated T2 signal on a fat-saturated T2. And then also these sub-end plate clefts are typical of findings in an osteoporotic compression fracture. This patient has myeloma and a compression fracture and pain at the thoracolumbar junction. We can see the lesions of myeloma, so which vertebral body is painful. Well, we have T2 hyperintensity here, we have the geometric deformity here, and the patient had pain with palpation at that level, and that's enough to provide us guidance as to where to intervene. Here's a very elderly patient with thoracolumbar junction pain, and here on the radiograph we can see this subtle sclerosis under the end plate, suggesting this is indeed a subacute fracture. And on the T2 weighted image, on the STIR image, we can see T2 hyperintensity. And here on the T1, we can actually see the fracture line visible there. Another case, an 85-year-old female with 2 months of axial lumbar pain. And again, the sclerosis indicating a subacute fracture and some mild marrow edema. Another case where we have geometric deformity in this inferior end plate, and then a kind of a pancake deformity of this vertebral body, diminished T1 signal, elevated T2 signal, a band associated with the fractured line, and in this level a zone of diminished T2 signal, also indicative of the fracture line. So contraindications, absolute contraindications. One of the big risks here is an infection, because we're introducing a foreign body. It's a significantly invasive procedure. So any septicemia is an absolute contraindication. Uncorrectable coagulopathy, obviously we're using an 11 to 8 gauge cannula to access the vertebral body, and allergy to the bone cement or the opacification agent. Then a number of relative contraindications. Important ones, if we're dealing with a tumor, we cannot have epidural extension of tumor. We may push that back and compromise the central canal. Or if we have an osteoporotic fracture, if we have a fracture fragment, which is retropulsed, that also potentially could be displaced by the installation of cement into the central canal. So the mechanism of pain relief is interesting. We started into this in the 90s without clearly understanding why it might get better. What's the pain coming from? Well, it was postulated at that time that the instability in fractures result in microscopic motion of the periosteum, and if we stabilize that with polymethyl methacrylate, that would eliminate that motion and pain. Alternative mechanisms of pain relief, we're instilling an agent, polymethyl methacrylate, which as it cures and hardens, has a significant exotherm. It generates significant heat, which will essentially ablate the basivertebral nerve. And also it's chemically toxic to the basivertebral nerve. So we may have been doing a basivertebral nerve ablation as well as a mechanical stabilization. And when we do a transpedicular access, we probably destroy the medial branch of the dorsal ramus. So if there is any component of posterior element pain, that may well be interrupted as well. Now it's important that we consider that in chronic fractures, we may be dealing with posterior element pain, not vertebrogenic pain from the compression fracture. Here was a nice paper by Bogduk and McVicker in 2010 showing particularly in patients with chronic fractures, the pain may come from the posterior elements. When there's a geometric deformity of this vertebral body, here when there's a wedge deformity, the superadjacent facet will be malaligned, and in a small series of patients, blocking this facet joint alleviated their axial pain. When you have a pancake deformity, it would be the infraadjacent facet joint, which would potentially cause mechanical impingement here and cause of chronic axial pain. So if I was in charge of the world, which I'm not, I tried to institute this in Mayo when I was there, but I was unsuccessful. Anybody more than 3 months out from a fracture, I would screen them with medial branch blocks at the appropriate level and see if this is posterior element pain before I would intervene in the vertebral body. So outcomes. This is really controversial because in the initial results in the early 2000s seemed great. A lot of these people got better. As a practitioner in that time, I always thought this is really wonderful stuff. Well, sometimes, and I really expected that a randomized control trial would confirm that clinical impression, and I was wrong. In 2009, there were two RCTs in the New England Journal of Medicine. The INVEST trial the PI was Dave Kelmus at the Mayo Clinic, one of my colleagues. And also the Bookbinder trial, this was in Australia. These were both vertebroplasty versus sham trials. And in the sham procedures, the patient was brought to the OR, they were given mild sedation, their skin was anesthetized, a needle was brought down to the pedicle was anesthetized, they opened the cement in the room because it had a smell to it. So the patient underwent a fairly rigorous sham procedure. And guess what? There was really no difference in outcomes in the INVEST trial or the Bookbinder trial. Very disappointing. There were some criticisms to these trials. In the INVEST trial, 60% of fractures were more than 3 months of age. Maybe it was posterior element pain. These did not require an MRI, so we don't know that they had marrow edema. The Bookbinder trial, both of these were probably underpowered. So they had challenges, but it resulted in a significant reduction in the use of conventional vertebroplasty. Subsequent randomized trials of sham versus vertebroplasty, the Vapor trial in 2016, now is selected for patients who are relatively acute, higher levels of pain, and had a positive MRI, and they had a favorable outcome. That's what I would have expected. And so I think patient selection is absolutely key. The Virtos trial in 2018 was less selective, older fractures, less pain, and they showed no difference in outcomes. But both of these trials showed durable vertebral body height restoration in comparison to those who were not treated or treated with the sham procedure had progressive vertebral body deformity. For your reference, here are all the clinical criteria in the sham-controlled vertebroplasty trials and all the vertebroplasty trials that have been done from a recent review article. There have now been meta-analyses and and reviews by august bodies, the American Society of Bone and Mineral Research, notes that, or states that in terms of vertebroplasty efficacy, there's no demonstrable clinically significant benefit over placebo or sham procedure, what they state to be high quality evidence. With a kyphoplasty or balloon-assisted vertebroplasty procedure, there's a small clinical benefit over non-surgical management or percutaneous vertebroplasty, or some of these other newer vertebral augmentation techniques, but with weak evidence. But if we look at population data, it's a little bit more interesting. A couple of nice studies looking at Medicare population data in the US. The first study with over 850,000 new vertebral compression fractures showed a survival advantage of those undergoing vertebroplasty versus non-invasive medical care at 4 years, 61% to 50%, highly statistically significant. And in a second study looking at over 1 million new vertebral compression fractures, those patients who had only standard non-invasive medical care had a 25% higher mortality versus vertebroplasty patients, and a 50% higher mortality versus balloon-assisted vertebroplasty patients. Those who just got standard non-invasive care had a higher risk of pneumonia, cardiac infarct, deep venous thrombosis, and UTI. So there is some data there suggesting we are helping these patients by treating them, but it's altogether remains controversial, I would be the best way to say it. In safety, we have looking at all the randomized controlled trials and the meta-analysis, the rate of serious complications was very low. What we might see are a leak of methyl methacrylate and possibly embolization to the lungs. Infection is always feared, and neural or central canal injury. Fortunately, with proper technique, those are rare. Risk of subsequent fracture has also always been considered in doing vertebroplasty, because you're putting a very dense material in the trabecular space of this vertebral body adjacent to relatively unstable or compromised osteoporotic vertebral bodies. But in several large studies of meta-analyses, there's been no clear-cut significant risk of adjacent level fractures. Those complications, what I just talked about, an example here where if you're not wary in terms of careful monitoring of your cement installation, it can leak into the epidural space and compromise the central canal. It can go to paraspinal vein and end up passing through the right heart into the pulmonary emboli, cause pulmonary emboli, which is obviously a very bad thing. Just to briefly now cover the technique of transpedicular access. This is what we use for vertebral augmentation and with some minor modification also for balloon assist for basovertebral ablation. So essentially what we're doing, here's an anatomic look at an upper lumbar vertebral body. We're going to take a large bore cannula. Notice the little yellow mark there, that's about where the medial branch lies. Well, guess where that very large needle is going to go, so we're probably going to obliterate it. Here we're showing going right down the major axis of the pedicle. That's ideal in terms of safety, but sometimes we have to modify that to get to the central portion of the vertebral body, both for vertebral augmentation and for basovertebral ablation. Once we engage that the cortex, we can drive that needle forward. That's easy in a osteoporotic vertebral body. It's relatively hard in a normal vertebral body, which will be present in basovertebral ablation. We have to be exquisitely careful about how far we advance that needle and look at it in multiple planes with each advancement to make sure that we are in the confines of the pedicle and not encroaching on the central canal. As the needle reaches the back of the vertebral body, the needle tip is at the back of the vertebral body, it cannot have crossed this cortical surface of the medial margin of the pedicle. If it crosses that line, we're in the lateral recess by definition. So as we advance, we look at a true AP, and when we are here, we're just going to enter the vertebral body. It is not yet to cross that line, so we're still safe. We're within the pedicle. How are we going to set that up? Well, we can look at, remember that we're going to look at cortical surfaces here. So here's the prone patient. We're going to rotate, and now we're going to see that medial cortex start to march medially. And when it's about halfway across, now we're ready to advance. And this is the trajectory that we will construct. We also have to think about the cephalocaudal plane, because it doesn't take much misalignment to pass underneath the pedicle and into that lateral recess. And to make sure we do that, we have to set up the cephalocaudal orientation. Note that here we have a significant loss of vertebral body height. Here are the end plates, and the pedicle is up here. If we go straight down that pedicle in that plane, we're going to end up in the disc. Rather, what we want to do is align the pedicle over the center between the perceived end plates, as we see here, and that will allow us to access the vertebral body safely. Just walking through and doing this, here we're in the oblique working position. We'll anesthetize the pedicle in 2 planes. There's our 11 gauge cannula, get cortical purchase. And now advancing that, notice we're well clear of the medial aspect of the pedicle. Advancing down the pedicle, again, well clear of the medial aspect of the pedicle on a true AP. Still clear of the medial aspect of the pedicle, both on the oblique and the true AP, and now we're at the back of the vertebral body. So now we can safely advance into the vertebral body. And now it's okay that we've crossed that medial pedicle boundary on the AP view, because we are in the vertebral body and can continue to advance to our preferred location. Just some cases, here's a significant geometric deformity, one with that little sub-end plate cleft. We have to very carefully set up that trajectory, because there's not a lot of room here, but it can be done. And then when we reach the optimal location, instill the barium infused methyl methacrylate. The very dense material here is in that sub-end plate cleft. Another example, setting up the proper orientation. Needle engaging the cortex, advancing to the back of the vertebral body. This for a balloon-assisted vertebroplasty, now in the central vertebral body, inflating the balloon, and then through that, through the cannula, you can instill a relatively viscous material. So in summary, osteocrotic vertebral compression fractures are highly prevalent. They cause morbidity and mortality. That's clearly true. Vertebral augmentation, however, is not well supported by high-quality evidence. The best data occurs in acute or subacute patients with significant pain and MRI showing marrow edema. So we have to use very good selection criteria, as in all our therapeutic procedures, as you've heard repeatedly over these last 2 days. Population data supports using balloon-assisted vertebroplasty over conventional vertebroplasty as superior to medical care in reducing morbidity and mortality. In chronic pain may be the posterior element origin, and perhaps in chronic pain patients, you should screen them with medial branch blocks before you intervene in the vertebral body. Thank you much for your attention.